So I'm going to give a talk today on neuroprognostication after cardiac arrest. I have no disclosures or conflicts of interest. During this talk, I will be addressing the new Neurocritical Care Society guidelines, and then I'll also like to acknowledge one of my colleagues, Dr. Sharma, who gave a similar talk, who granted some of his slides. So I'm going to discuss the epidemiology of cardiac arrest, just the need and also the history of neuroprognostication, and then we will cover the 2023 Neurocritical Care Society guidelines. So the cardiac arrest registry to enhance survival looked at 100,000 patients that had an out-of-hospital cardiac arrest. Actually rephrase. There were 100,000 patients. Out of every 100,000 patients, there are 88.8 that have an out-of-hospital cardiac arrest. Only 24% of those patients survived to hospital admission, and 9% survived to hospital discharge. And of those who survived, 79% had good neurological outcome. For those patients who had in-hospital cardiac arrest, there were 10.16. There were about 10 patients per every 1,000 admitted to the hospital. 27% of in-hospital cardiac arrest actually survived to discharge, and 80% had a good neurological outcome. So the take home from these two slides are, there is a high mortality associated with cardiac arrest. However, if you survive to hospital discharge, you often will have a good neurological outcome. So what is cardiac arrest and how does it affect the brain, right? So cardiac arrest, as we all know, we're neurologists in the room, is a big bad stroke. That's really what it is, to the entire brain. Different parts of the brain have different vulnerabilities to ischemia. So the brainstem is actually the most resistant and is the least affected. The duration of global brain ischemia is important, right? Just depending on how long this cardiac arrest occurs, patients can progress to brain death, at least as we would call it in the United States. I do know that there's no brain death law, particularly in the Dominican Republic, but Dr. Kaufman will be addressing brain death this morning. So what do we see on CT scans with patients who've had cardiac arrest? The top image is just a CT scan that shows diffuse cerebral edema. There's loss of gray-white differentiation. And then if we do an MRI, we often have this sort of whole brain cortical restricted diffusion that indicates diffuse axonal injury. So I have a question for you all. This will be an interactive sort of talk. In the United States, and actually in most of the world, what is the most common cause of death after cardiac arrest? And this is for anyone in the audience to answer. There were some, you can raise your hand. What do you think is the most common cause of death after cardiac arrest? It's not arrhythmia. That sounds familiar. I gave this talk yesterday to the residents, and that was the first thing someone said. But it's not arrhythmia. It is withdrawal of life-sustaining therapy. So there was a 2022 TELSTAR study that showed that the most common cause of death after cardiac arrest was actually just taking people off of the ventilator. Saying that there was a cardiac arrest, they're going to do badly, and then they got taken off the ventilator and they died. And this occurred in 40 to 80% of comatose survivors after cardiac arrest. Oh, if you wanted. Okay. All right. So neuroprognostication actually began in the 1970s after ventilators came into vogue and were being used all across the US and all across the world. Patient autonomy in the United States particularly only became an important concept in 1975 when there was this girl, this is her picture, Karen Ann Quinlan, who actually overdosed. And she had a cardiac arrest. She was on a ventilator. She was in a persistent vegetative state. Her parents, there's a picture of her parents. Her parents did not want her to spend the rest of her life in this, persistent vegetative state. However, the laws in the U.S. at the time did not allow anyone to be disconnected from the ventilator. They actually sued the hospital. It led to a big Supreme Court trial that eventually changed the law. And in the U.S., they became the right to die law, actually, which is, if your loved one or yourself, you're in a state that you would not want to spend the rest of your life, hooked up to machines, hooked up to feeding tubes, then you should be allowed to go through the natural process of death. And that sort of changed the entire approach of medicine and actually post-cardiac arrest care in the United States that allowed more patient autonomy, more families to make decisions for their loved ones regarding, keep them on a ventilator or not. So neuroprognostication is important because it does establish realistic expectations for families, right, and surrogate decision makers. It also determines resource mobilization. Because as we all know, it takes a lot, right? It takes a community to take care of people who have suffered a cardiac arrest and as a result have devastating brain injury, right? Those patients may need tube feeds, will need round-the-clock care, and just mobilizing those resources will be important. Okay. And neuroprognostication is even more crucial as it affects to infants and children because they can also suffer cardiac arrest. And this shared decision making is important because sometimes our values as physicians and neurologists are not the values of the family themselves. There's often sometimes there's a discrepancy in what we think is right versus what families think is right. So neuroprognostication and just having a good idea as to, will this patient wake up is important for everyone. So the first paper on predicting outcome from hypoxic ischemic coma was published by Levy in 1985. And that led through numerous studies to, I think, what most of us know in the room, the American Academy of Neurology 2006 practice guidelines for neuroprognostication after cardiac arrest. I'm just going to walk through this briefly, and then we will explore how this has changed with the new guidelines. So for our comatose patients, the first thing that we should do is exclude major confounders, right? You don't want to examine a patient, say they're comatose and they're on propofol or midazolam. You need to make sure that those things are removed. If there are no brainstem reflexes at any time, the 2006 guidelines actually said that we can proceed with brain death testing. On day one, if there was myoclonus status epilepticus, they said that indicated a poor outcome. On day 1 to 3, somatosensory evoked potentials can be done, and if there's an absent N20 response, that also indicates a poor outcome. Serum neuron-specific enolase, greater than 33 if you have the capability to measure it. I will say that I have never sent this lab in my life, and I don't know many people who have. Have you ever sent that here? Okay. If that is greater than 33, then they said that suggested a poor outcome as well after cardiac arrest. And if you examine the patient on day 3, and there was still absent pupil or corneal reflexes, so note they said pupil or corneal. If there was an extensor or absent motor response, they also said that this is a poor outcome. If the answer to any of these questions was no, there was an indeterminate outcome. So from this algorithm, things to take home, there was no suggestion as to what would be a good outcome, right? There's only poor and indeterminate. And there's several things that, SSCPs, often not done either. I've never ordered an SSCP. Have you ordered SSCPs here? Anyone? Okay. So there's several tests also that are not available to many neurologists that indicated a poor outcome, and actually we'll go through several of these things and indicate that most of them have changed. There were several criticisms of this 2006 American Academy of Neurology guideline, notably that it was really based on studies before the advent of therapeutic hypothermia, and now there's targeted temperature management. So it's done, these studies were from the days before we do what we do now to every cardiac arrest patient. Also, a lot of the studies didn't really address, the influence of sedatives, neuromuscular blockade, making sure that they were removed. And then also, these thresholds, such as serum neuron-specific enolase greater than 33, have been proven in multiple studies to be erroneous, that there was no real threshold, and the only threshold you could have was if you had a patient's baseline to start with, to know how much higher it went after cardiac arrest. Also, they did not address many of the things that we do now, right? Patients have cardiac arrest, we order CT scans, that was not addressed in the 2006 review. If we have MRI capability, we will order MRIs. If we have an EEG, we will order an EEG. And none of these things were addressed in the prior American Academy of Neurology guidelines. That led to the European Society of Intensive Care Medicine in 2014 also publishing their own algorithm for neuroprognostication. And this one also said that if, you should wait at least 24 hours, they said at least 24 hours after cardiac arrest before making any sort of assessment for prognosis after the cardiac arrest in that patient. And if there are two or more of the following, including status myoclonus, less than 2 days after return of spontaneous circulation, if there were high neuron-specific enolase levels, if there was an unreactive EEG, burst suppressed or status epilepticus on EEG, if there was diffuse synaptic injury on brain CT or MRI, that poor outcome was likely. Okay. So then the Neurocritical Care Society decided that, we had the original American Academy of Neurology guidelines. There were also these European Society guidelines, and there needed to be some clarity between Europe and also the US in terms of how do we assess patients after cardiac arrest, and how can we prognosticate if those patients will do well or not after suffering a cardiac arrest. And this guideline was actually published in late last year in 2023. So they looked at these clinical variables and tried to assess from these variables if any of these variables would make an impact in prognosticating after cardiac arrest. And they used many common clinical variables, so things that neurologists were already using, and they also looked at the variables that were published in the European guidelines and also in the American Academy of Neurology guidelines. So they looked at age. They wanted to know, is the initial cardiac rhythm, is that important in prognosticating after cardiac arrest? Is the time to return of spontaneous circulation. So basically the time of your CPR until that patient has regained a pulse, is that important? The best MOHO response, so the American Academy of Neurology guidelines did mention, if you had extensor posturing, that was a poor outcome sign, so they looked at that as well. They looked at the bilateral absence of a pupillary light response, myoclonus less than 48 hours from return of spontaneous circulation, and then they also addressed imaging findings, so your CT scan findings and your MRI brain findings, and they also included EEG findings. Did a suppressed or burst suppressed background, did that indicate that there was poor prognosis after cardiac arrest? And they also addressed SSCP testing, given that that was in both guidelines, it was mentioned, and then also the level of neuron-specific enolase. They looked at different clinical prediction models, the out-of-hospital cardiac arrest model, the cardiac arrest hospital prognosis model, and good outcome following attempted resuscitation. And the question that they phrased for each of these variables was, when counseling family members, should whatever that variable is, so age, should the CT scan finding, should the MRI finding be considered a reliable predictor of outcome or not? They initially started with, through the literature review, 3,539 records, and then whittled it down to 72. So in the grading of these guidelines, you'll see that a lot of this is actually going to be like poor quality evidence overall, but just because, you know, there's 72 studies, there are no real randomized controlled trials for a lot of this stuff. So the quality of evidence, as you'll see in the guidelines, was not the greatest for any of their recommendations. So we will note that as we look at all of their recommendations. I'll skip this slide for now. They did recommend, before even going into each variable, they wanted to address things that we as neurologists should make sure that we do every time that we see a patient who has had cardiac arrest and we're going to make, we're going to prognosticate. They recommended not assessing patients for neurological prognosis until at least 72 hours following return of spontaneous circulation in patients who were not treated with therapeutic hypothermia. So, and at least 72 hours following rewarming in patients treated with hypothermia. So that means that, you know, you have a patient with cardiac arrest, and often they get admitted to the ICU, and then the pulmonary critical care doctor consults you as a neurologist on day one, and they want to know, you know, what is the prognosis for this patient? Your answer should be, I'll come back on day 3. And then also they said that persistence of coma beyond this 3-day mark should not be equated with a poor neurological prognosis. So even when you show up on day 3 and that patient's still comatose, you should not say that that patient will have a poor prognosis. And that was actually based on the study that was published in 2022 in Critical Care Medicine. In a Taiwanese population. In Taiwan, if you have a cardiac arrest and you are ventilator dependent, you will remain ventilator dependent sort of like for the rest of your life. The country has a lot of resources. They will, they will perform a tracheostomy, a feeding tube, and they will keep you on the ventilator. Withdrawal of life-sustaining therapy is not a cultural norm there and is not done. So they were able to look at patients who were just indefinitely on a ventilator after cardiac arrest, and they actually found that up to nearly 10% of patients actually had a recovery of consciousness more than 7 days after return of spontaneous circulation. Meaning that, you know, the earlier American Academy of Neurology guidelines that said, you know, you can make this decision on day 3 did not actually pan out, because up to 10% of patients would actually wake up after 1 week, okay? So that led to the cutoff mark being, you know, you can wait. Typically now in our hospital, we will wait a week before we definitively say that someone will not wake up. They also, of course, recommended, as we already said, that while assessing these patients, you make sure that there's no sedation on board or any other potential confounders. You know, if you have a patient who's in renal failure and needs dialysis, make sure that they're being dialyzed before you even say that the patient will not wake up. You know, we often look at the patient's prior baseline, right? If you have someone who's wheelchair bound or someone who's older, we tend to let that also influence our decision as to how well they will do in the future. The Neurocritical Care Society guidelines also said that we should not do that on its own. Because there are patients who, you know, even if you're wheelchair bound or you're not, and you have a cardiac arrest, there are many other factors that go into determining what your outcome ultimately will be, and you should not use that alone to say that someone will have a poor outcome. They did recommend that you looked at the entire picture, basically. So not just one variable, but multiple variables. So just how I said, if you're like an older patient won't do well, you shouldn't say an older patient won't do well, but you can look at several variables to determine if someone will have a poor outcome or not. And then they said that, if you cannot find any reliable predictors of outcome, then you should just say that you don't know, that the prognosis for that patient is uncertain. And how should you counsel family members after saying you don't know? You just say that, we do know, like from this Taiwanese trial, that if you wait 7 days, after that point, you kind of have diminishing returns and most people will not wake up. So you can also just do that. If you don't know, you can wait before you give a prognosis to the family or to the palm critical care doctors. So they recommended, as I just said, an extended period of observation for signs of neurological recovery in those that we don't know if they will wake up or not. So now I'm going to go through all of the variables and then also their recommendations. So age is the first thing they looked at, and based on these 70 plus studies, they suggested that the patient's age alone should not be considered a reliable predictor of poor functional outcome assessed at 3 months or later. Of note, this is a weak recommendation with low quality of evidence just because there are not that many studies out there, and there, as I said, not any randomized control trials. The initial cardiac rhythm, some people have suggested in the past that a shockable versus an unshockable rhythm could portend a poor prognosis. They disagreed, and they said the initial cardiac rhythm does not matter and is not considered a reliable predictor of poor functional outcome either. How about the time to return of spontaneous circulation? So, we always got those consults where you have a 2-minute cardiac arrest or you have a 20-minute cardiac arrest. And I think when I hear a 20-minute cardiac arrest, I'm already biased as to thinking that patient will not do well. Based on their studies, however, they also said that alone, the time of return of spontaneous circulation, is not considered a reliable predictor of poor functional outcome. And we can think of it just generally from the stroke sense too, right? We often see these patients who come to the hospital quickly after stroke. They're 4 hours after their last known well time, and they still have a huge stroke. And then sometimes we see someone that presents 21 hours, and they don't have a huge stroke, even with like an MCA occlusion, and those patients can still go to thrombectomy and can still do well, and it just depends on collateral flow and blood supply, et cetera. And the same thing they're saying could be the case here with this whole brain stroke, because we just don't know. Every patient's different, so the time may not be that important of a determinant by itself. How about the absence of a pupillary reflex more than 3 days after return of spontaneous circulation? They did find that this was a reliable predictor of poor functional outcome at 3 months after cardiac arrest. So this is one thing that from the prior 2006 guidelines that they did agree with. So if you examine a patient, it's 3 days after cardiac arrest, there's no reaction of pupils to light, then those patients typically will not do well, will not wake up, and will remain comatose. The American Academy of Neurology guidelines also assessed the corneal reflex and said that if it was absent at 3 days, that was a poor indicator of improvement of functional outcome and awakening. These new guidelines disagree. So corneal reflex is absent 3 days after the cardiac arrest. This is not a reliable predictor of poor outcome. How about extensor posturing? This also in the prior guidelines from American Academy of Neurology said that would be a poor indicator of awakening. Again, that did not pan out. And the new guidelines say that this should not be considered either as a reliable predictor of poor functional outcome assessed at 3 months or later. I think when I was a resident, if someone was in status myoclonus after cardiac arrest, I think we just wrote poor functional outcome and actually recommended withdrawal of, we actually didn't treat it that aggressively either when I was a resident, because we were like, okay, they're going to do badly, they're not going to wake up, so why bother treating it aggressively? These new guidelines suggest that this is also incorrect, and that it's not a reliable predictor of poor functional outcome by itself, and that there are patients who have had status myoclonus after cardiac arrest who have woken up. How about our CT brain findings? So as we know, this was not addressed in the prior guidelines. So CT scans we can use to predict if someone will have a good outcome or not. So if we do a CT scan, and of note, the CT scan should be done more than 3 days after return of spontaneous circulation, and that CT scan shows loss of gray-white differentiation across vascular distributions and diffuse cerebral edema. That CT scan does indicate that these patients will remain comatose. If we have MRI capabilities and our MRIs show extensive not sick brain injury, then this also is a predictor of poor functional outcome. So CT scans and MRIs can help us. How about EEG? If we have EEG capability and we place an EEG on these patients after cardiac arrest, and there's a suppressed or burst suppressed background, and the EEG is at least 72 hours. So everything sort of has to be done 3 days or more from return of spontaneous circulation. Then that EEG is actually a reliable predictor of poor functional outcome. Of note, MRIs can be done slightly earlier. It can be done at 48 hours. But CT scans, we should wait at least 3 days. Some other sensory evoked potentials. If you have the capability and can do them, then if you perform them 2 days or more after the cardiac arrest event, and the N20 wave is absent bilaterally, then this is still a reliable predictor of poor functional outcome. So SSEPs are still beneficial and helpful. And this just shows the SSEP N20 measurement, and this is the wave that you would be looking for after stimulating the median nerve. Neuron-specific enolase, as I mentioned, we really don't know what the range should be in an individual person. So this is no longer considered to be a reliable predictor of poor functional outcome. Okay. All right. So looking at this chart, a lot has changed really from the American Academy of Neurology guidelines. I think what I learned as a resident is no longer the case. And this is actually one of the, I think, will change our practice, drastically has changed my practice in the last 6 months. So now, we do look at pupillary light response. In our hospital, we have something called the pupillometer. I don't know if you know what a pupillometer is. But it's a device that actually shines light into the eye, and it measures the size of the pupil and contractility. And we will use that when we can, just to make sure that, when we say the pupils do not react to light, that we're positive that they do not react to light, and that we actually have an objective measurement of pupillary response. Neurological exam is important, of course. Our extensor response no longer really indicates if it's going to be a poor outcome or not. CT scan and MRI is important and can help us actually in predicting outcome after cardiac arrest, and EEG and SSEPs still can help us as well. So this led to this new algorithm recommended by the Neurocritical Care Society for neuroprognostication. So when we have a patient that presents to the hospital with cardiac arrest, they broke it down into what to do on different days, which is very helpful to us on our day-to-day clinical practice. So on day one, meaning less than 24 hours post-resuscitation, You can initiate targeted temperature management, EEG, if you have continuous EEG capabilities, which a lot of hospitals don't, honestly, and even at my hospital, it can be challenging, especially on weekends or nights. We're very good covered during the daytime, but after 7 p.m., it's hard to get a continuous EEG. If that is available, then you should put one on. And then you can consult neurology on day 1. On day 2, if you have cooled, a lot of hospitals are no longer doing hypothermia after cardiac arrest with the new studies and guidelines, but are now doing aggressive normothermia. But if you have cooled, you should begin rewarming on day 2. On day 3, you should completely wean off sedation and see how that patient is doing clinically and perform your neurological examination. CT scans can be ordered on day 3. And then also, if available, you can do SSCPs, or you can order an MRI if this will help you assess if, the patient who's now comatose after suffering a cardiac arrest is, has signs of diffuse axonal injury and brain injury after cardiac arrest. On day 4, if therapeutic hypothermia was not used, and the patient is normothermic, so making sure that the temperature is normal, then you can document your EEG findings. And if you have started an EEG on day 1 and there are no seizures on day 4, you can probably discontinue it. And then also you can, this is when you will see if your pupils are still not reactive to light. So remember the prior AAN guidelines also, if pupils are not reactive to light on day 3, they've sort of moved it down to this day 4 category, which is still 72 to 96 hours post-ROSC. And then on day 5, you can still continue to focus on your neuro exam to help you make a decision. Okay. This algorithm leads us to this sort of flow chart, and the take home from this is these are the first guidelines that tell us, if someone has a good prognosis. Before, we could only say poor prognosis or indeterminate prognosis, but these guidelines actually, suggest things that determine if someone will have a good prognosis or not. So if, your patients are following commands at any time, then clearly that is a good prognosis. If, they've suggested also waiting 24 hours after rewarming to 36 degrees Celsius before pursuing brain death testing. If you do your exam and there are no brainstem reflexes at all, then you can pursue the pathway of death by neurological criteria. What are the predictors of a good outcome? So from these new guidelines, we now have, that if someone is withdrawing or localizing, that actually is a predictor of a good outcome. If you do your MRI and there is no evidence of diffuse restricted diffusion or hypoxic ischemic injury, then that actually is a good predictor as well. If you do your EEG and they have a good background, then great. That is also a good predictor. And if you do your SSCPs and the N20 amplitude is present and it's been more than 2 days after the cardiac arrest, then that also is a good predictor. So what are the reliable predictors of poor outcome? So your absent pupillary light response at day 3 is still a predictor of poor outcome, and then absent N20 waves. And then the moderately reliable predictors, so they divide it into what is definitively a poor outcome and what is maybe a poor outcome. If your CT scan findings show diffuse loss of gray white differentiation, if the MRI shows evidence of hypoxic ischemic injury, or your EEG has a suppression or burst suppression background, then that is probably going to be a poor outcome in that patient. So this is just highlighting that these are the first guidelines to focus on the good, not just the poor. All right, and then that will bring us to our cases. All right, so this is a 65-year-old man, history of hypertension, diabetes, and he was admitted to the ICU following a witnessed out-of-hospital ventricular fibrillation cardiac arrest. CPR was initiated within 3 minutes. And defibrillation was performed by emergency medical services upon their arrival. The total downtime until a return of spontaneous circulation was 15 minutes. The patient was admitted to the hospital, to the ICU, and then underwent targeted temperature management set at ensuring aggressive normothermia, 36 degrees Celsius for 24 hours. On day 2, post-return of spontaneous circulation, the patient was still comatose. GCS, his Glasgow Coma Scale, was 3T. And then you were consulted as a neurologist by the cardiology team to help prognosticate. So the first question for you all is, according to the guidelines, how long should you wait before attempting neuroprognostication in a comatose patient post return of spontaneous circulation when not using hypothermia? And you can raise your hand. We'll do it that way. A, B, C, or D. So 24 hours is A, B, 72, C, 48 hours. D, immediately upon return of spontaneous circulation. B. Yeah, so 72 hours is the correct answer. So remember that we should wait 3 days, basically. All right, so you return to examine the patient on day 3, and there's no change in the exam. The Glasgow Coma Scale is still 3T. Which of the following is considered a reliable predictor for poor functional outcome when assessed correctly? So is it A, your best motor response alone, B, bilateral absence of pupillary light response, C, EEG showing generalized slowing, or D, the patient's age? B, yeah. So that is like one of the things that we have been doing that has still panned out with these new guidelines, okay? But the corneal reflex, remember, that's not something that we should say is a poor outcome indicator. All right, so case 2. So this is a 70-year-old woman with a history of chronic kidney disease and atrial fibrillation. She suffered an in-hospital pulseless electrical activity, cardiac arrest, and return of spontaneous circulation occurred after 20 minutes of CPR. She then underwent targeted temperature management for 24 hours, and now it is day 4 after return of spontaneous circulation, and she remains comatose. Her Glasgow Coma Scale is a 4. She's currently receiving renal replacement therapy, which is dialysis, and has received sedatives. So which of the following is crucial before performing neuroprognostication in this patient? Is it A, waiting for the sedation effects to wear off, B, ensuring renal function is stabilized, C is both A and B, and D is you just order imaging regardless of anything else that's happening? C. Yeah. Yeah, these are easy questions. All right. In the presence of confounding factors, so you know that she is a patient on dialysis, you've held her sedation, she's got, but you're still concerned that maybe the sedation is not, all the way washed out yet. Which approach enhances the accuracy of neuroprognostication? Should you solely rely on your clinical exam? Should you think about ordering an EEG and an MRI? Should you say, she's on dialysis, she's older, she had a 20-minute cardiac arrest, she probably won't do well, and then you just tell the family she probably won't do well. Which approach should you use? B, yeah. So that's what you should do. Okay. But I think we would all agree she probably wouldn't do well. Okay. All right. So our take home from this is, early family involvement should be key, right? Just remember that whatever our own values are is not what the family's values are. And then we also need to consider, because families, sometimes want to do everything under the sun, but they don't understand what that means, which is why when we have these situations, we will have numerous family meetings where we'll sit down for an hour at a time. We'll go over all the imaging. We'll have our case manager or a social worker there, because sometimes families are like, we want to do everything. And then they learn that doing everything means that they need to have like 4 family members really agree to work around the clock just to like turn patients feed them, clean them. And after explaining what life will be moving forward, some families decide that they really don't want to do everything because they don't have the capability to do everything. And you need to have a lot of financial support to do everything. And even in the United States, a lot of insurance companies will not pay for long-term care. So families have to do this on their own. Aggressive normothermia, 36 to 37 degrees Celsius, is what we recommend now, and we do at our hospital after cardiac arrest. If there's brain death consideration, then we will just assess for brain death. But Dr. Kaufman will talk more about that shortly. And then also continuous EEG monitoring is recommended if you have the capability to do it. Most hospitals in the United States don't have the capability to do it. I think in Georgia, my hospital is probably like one of 4 or 5 that does it every day, basically. And we have to turn patients away. I got numerous calls a day, and I have to say no, just because we don't have the bed capability to take every patient that needs a continuous EEG. And then we also will involve our social workers and our case managers in the hospital early in this patient population, given that there will be many needs moving forward. And then this is just a picture of me and some of my colleagues in our neuro ICU. Thank you very much.